Hello and good day to everyone. I welcome you to our Congress and invite you to enjoy the fun listening to our elite speakers. We shall start our first title by it's an elite speaker who will be presenting to us today. Dr. Carla Moran is a consultant endocrinologist at the Beacon Hospital in Dublin and an associate clinical professor at University College Dublin School of Medicine. Dr. Moran has completed a fellowship and a PhD in thyroid disease in the University of Cambridge, focusing on thyroid hormone-resistant topic. She has provided a clinical service for immune checkpoint inhibitor endocrinopathy as well. Dr. Moran has established a national referral service for rare thyroid disease in Ireland. She is an editorial board member for the Journal of the Endocrine Society, and she is an invited member of the UK and European Guideline Development Committees for Thyroid Disease. So please welcome me to listen to Dr. Moran for the first topic, which is thyroid hormone resistance, an update.
Hello and good afternoon, everybody. It is such a pleasure and an honor to be here to give you this talk on resistance to thyroid hormone. And I know I've been given the privilege of giving your first lecture of your Congress, and I thank you very much for inviting me to do this. And I'm very much looking forward to being able to give you this talk. My name is Carla Moran. I'm an endocrinologist. I work in Dublin, and I have a particular interest in resistance to thyroid hormone, having completed my PhD in that subject and having worked and looked after these patients for many years. So I am going to give you an overview of resistance to thyroid hormone, and I hope you find it interesting. And I hope that at some stage in your career, you'll be able to use some of the messages that you've heard in this talk for your own patients. To start off, I'd like to just give an overview of thyroid hormone action. So you'll all be very familiar, of course, with the HPT axis, and you'll know that the hypothalamus produces TRH, which in turn stimulates the synthesis and release of TSH from the pituitary gland. And TSH then mediates the steps in thyroid hormone biosynthesis in the thyroid gland. The thyroid gland predominantly secretes T4, smaller amounts of T3. And thyroid hormones circulate in the blood and arrive at target organs, including the liver, where they control cholesterol metabolism, SHBG production, amongst other things. They exert chronotropic and inotrophic effects on the heart. They have an important role in brain development and myelination of the brain. And the bone, they control bone maturation, turnover, and our growth. And they're an important determinant of our metabolic rate, particularly at the level of the skeletal muscle. Thyroid hormones exert a negative feedback effect on the pituitary and hypothalamus. So once thyroid hormones arrive at their target cell, they enter the cell by active transport through thyroid hormone transporters, which are located on the surface of the cell. When T4 enters the cells, it's converted to T3 by deiodinase enzymes. And T3, as you know, is the active form of thyroid hormone. And it binds to the thyroid hormone receptor, which is located within the cell nucleus. And the thyroid hormone receptor is usually bound to specific regulatory sequences in the target genes called TREs, thyroid hormone response elements. And the presence of T3 having bound on the thyroid hormone receptor then results in changes in gene transcription, and it usually transactivates target genes, but it can inhibit their transcription also. A really important concept in the pathogenesis of resistance to thyroid hormone is the understanding that tissues preferentially express one or other thyroid hormone receptor. So we have two types of thyroid hormone receptor, alpha or beta, and the hypothalamus, pituitary, and liver preferentially express the beta form of the receptor. And the skeletal muscle, bone, brain, and heart preferentially express the alpha form of the thyroid hormone receptor. When we think about resistance to thyroid hormone, this resistance can occur at various levels in the pathway of thyroid hormone action. So resistance can occur at the level of the thyroid hormone receptor, and that can be due to defective signaling through the alpha form of the receptor or the beta form of the receptor. There can be defects in thyroid hormone transporters, such that the T4 and T3 don't enter the cell as normal, and the MCT8 defects are an example of this, and I'll describe these to you. The other possibility is a problem with thyroid hormone metabolism, and this can be brought about by deficiency in SPP2, and I'll briefly discuss this also. Most is known really about RTH beta, so I'm going to start describing this condition to you. And I'd like to start off with a case. So this is a patient that I looked after since I came back to Dublin over the last 2 years. He's a 42-year-old male teacher and competitive swimmer, and he presented to a local emergency department with acute left face, arm, and leg weakness, and he had an acute infarct in the right MCA territory, as shown here. He had a background history of atrial fibrillation since the age of 30, and he also had a history of anxiety. He underwent thrombolysis after presentation, but unfortunately he developed a further stroke, and he had occluded his basilar artery. This required a thrombectomy, and this was further complicated by hemorrhagic transformation. So it was a very devastating event for this young man, and indeed he's still recovering from his stroke, which happened 2 years ago. Throughout the time, his atrial fibrillation was very difficult to control. And so one of the tests that he had performed was thyroid function tests. And you can see here that his TSH is within the normal range. His T4 is raised, and his T3 is also raised. So when we see a pattern like this, there's a number of different reasons why patients could have hyperthyroxanemia with a non-suppressed TSH. So assay interference is a very common cause. Displacement of thyroid hormones from binding proteins, such as that brought about by heparin, for example, or TSH secreting pituitary tumor could be a cause. And this patient had investigation for assay interference, and he was actually found to have resistance to thyroid hormone beta. He had a gene sequencing of THRB, which encodes the beta form of the thyroid receptor, and he was found to be heterozygous for the M313T mutation, which is known to confer RTH beta. So his diagnosis is RTH beta, but the question is his stroke in any way a consequence of having RTH beta? Is the atrial fibrillation related, and should he undergo any further investigation or treatment? So at this point, I'd like to do a little recap on RTH beta. So this condition was initially described in 1967 by Samuel Refetoff, and its frequency was felt to be around 1 in 40,000, but a recent paper has shown that its frequency in Spain was 1 in 19,000. And it's brought about by defective signaling through the beta form of the thyroid hormone receptor, and TR beta is encoded by THRB on chromosome 3. The cartoon here is a very simplified representation of the beta form of the thyroid receptor. And you can see that it has a T3 binding domain and it has a DNA binding domain. The majority of mutations, all of the mutations that are described affect the T3 binding domain and not the DNA binding domain. And as I've mentioned before, TR beta is predominantly expressed in the liver, hypothalamus, and pituitary, and it's also expressed in the cochlea and the retina. The majority of patients have missense mutations, and most of these are heterozygous, but patients can have a homozygous mutation, and they can have frame shift or premature stop mutations. Those patients seem to be more severely affected. Most patients will have inherited the condition in an autosomal dominant fashion, but a small number arise de novo. And both the age and the phenotype at diagnosis is very variable. And this is an example of a young boy who was 9 years of age when I met him. He was referred by Dr. Habib in Saudi Arabia, who had a homozygous form of resistance to thyroid hormone. And he unfortunately had quite significant cardiac problems and sadly died of heart disease at 11 years of age. So you can have that quite extreme phenotype. But on the other hand, you can have patients who are relatively asymptomatic, and it's picked up just on routine thyroid function test checks. All patients with RTH beta will have abnormal thyroid hormone biochemistry. So these are the results of TSH, T4, and T3 in over 80 patients with THRB mutations who were assessed in Cambridge. And you can see that in general, their TSH tends to be within the normal range, which is shown by the shaded blue box. Some of them have a raised TSH, but none of them have a suppressed TSH. The free T4 is invariably raised, and the free T3 is almost always raised. The other thing to note is that the height of elevation of the T4, T3 is very variable. So some patients just have a mildly elevated T4, and some have a T4 that's almost 4 times the upper limit of normal. And this TFT pattern reflects the resistance at the level of the hypothalamus and pituitary to thyroid hormone action. Another recently described feature of resistance to thyroid hormone is dyslipidemia. So we analysed lipid profiles in over 70 patients with confirmed RTH beta, and you can see that compared to controls and thyrotoxic individuals, their LDL is higher, their triglyceride levels are also higher, and their HDL is lower. And this is reminiscent of the metabolic syndrome. So we assessed other features of that syndrome and found that indeed patients with RTH beta had increased intrahepatic lipid content compared to controls. They also had increased intramyocellular lipid content, and they had a raised HOMA-IR, signifying some insulin resistance. And we suspect that there's multiple reasons why these abnormalities occur, but certainly the hepatic resistance plays a large part in these features. So patients are resistant at the level of the hypothalamus, pituitary, and the liver. But as I've shown you, their thyroid hormone levels are high. And signaling would be expected to be normal through the alpha form of the receptor because it's encoded by a different gene, which is not affected in this condition. So the tissues that predominantly express alpha are exposed to relatively high thyroid hormone levels. And that's the case throughout these patients' lives. So one might expect that they have cardiac phenotype. And indeed, George Kahali measured heart rate in patients with RTH beta and found that it was raised in between that of euthyroid and thyrotoxic individuals. And a high proportion of patients with RTH beta had atrial fibrillation, 6% of them. And bear in mind that patients who were in this study, their average age was only 42, so that's estimated to be 20-fold greater than it should have been. You'll know that in thyrotoxicosis, patients have a raised basal metabolic rate or resting energy expenditure. And you might expect that patients with RTH beta would also have a raised energy expenditure because they have excessive thyroid hormone exposure to their heart and to their skeletal muscle. And both of these organs contribute to the resting energy expenditure. And indeed, when Krish Chatterjee, a former colleague of mine from Cambridge, measured resting energy expenditure in patients with RTH beta, he found that it was elevated in between that of controls and thyrotoxic individuals. So this is a summary of some of the features of RTH beta. They have abnormal thyroid hormone biochemistry, which I've shown you. 70% of them will have a goiter. They have dyslipidemia with raised HOMA-IR. They have cardiac features with palpitations, arrhythmia, and in extreme cases, cardiac failure. They have CNS features, including ADHD, poor attention concentration, reduced IQ in 30% of individuals, hyperkinetic behavior, and anxiety. Low bone mineral density is seen in adulthood, and in children, they often have delayed bone age and short stature, but there does seem to be catch-up of growth later on. And patients have raised metabolic rate, which I've shown you, and this often results in failure to thrive in childhood. ENT infections are more common, and hearing impairment is quite common in these patients as well. So if we go back to our case, we measured his lipid profile, and it was not particularly remarkable. We screened him for diabetes, and that was normal. And I felt that he had quite a predominant cardiac phenotype. And I felt it would be beneficial for his heart if we lowered his thyroid hormones. And so I started him on carbimazole, and you can see that his T4 comes down. But unfortunately, with time, you can see that his TSH really rises. And this is a very common problem with RTH beta. As you try to lower the thyroid hormones, the TSH really jumps up. The good news is that he had a reduction in palpitations. His Holter monitor showed a sinus bradycardia, and there was a reduction in his beta blockade dose. The problem long-term will be how will we manage this elevation in this TSH? So this is a diagram showing essentially the use of carbimazole in these patients and beta blockers as well to reduce the drive on the heart. But as we use the carbimazole, the TSH rises, and that TSH can stimulate the growth of the goiter, and it can also potentially result in pituitary hyperplasia. So it can be helpful to add in a medication called Triac. This is a thyroid hormone analog. It is triiodothyroacetic acid, and it preferentially stimulates the beta form of the receptor. So these patients are usually heterozygous, so they'll express the wild-type beta form of the receptor in the pituitary and the hypothalamus. And what we're hoping to do is, by activating that receptor, we are reducing the TSH drive, and so we'll hopefully prevent goitrogenesis, hyperplasia, and will also improve the T4, T3 levels, which often drop after Triac therapy. So I'd like to go on to discuss resistance to thyroid hormone alpha. So here the resistance is again at the level of the thyroid hormone receptor, but the defective signaling is through the alpha form of the receptor, and the beta form of the receptor is not affected. So you can see from this simple cartoon that the alpha form of the thyroid receptor has very similar structure to the beta form. It also has a T3 binding domain and has a DNA binding domain. And as I've mentioned before, it's predominantly expressed in the brain, heart, muscle, and bone. The alpha form of the receptor is encoded by THRA, which is a gene in chromosome 17. And patients with defective signaling through the alpha form of the receptor were first described in 2012, so fairly recently identified. The frequency is unknown, but over 50 families have been described now, and there have been more than 20 different heterozygous mutations. No homozygous mutations have been described as yet. The mutations can be frame shift, premature stop, or missense. And again, the mutations affect the T3 binding domain. The mutations can be autosomal dominant or de novo, and they're most often diagnosed in childhood for these patients. The phenotype, again, can be very variable, with patients who are quite severely affected to others who are just checked because their relative has been identified and then they are screened. These are the first 4 patients who were described to have RTH alpha. The first little girl was 6 years of age, and she'd had a history of developmental delay. She had short stature, and you can see that she had an increased head circumference as well. She's quite an obvious protuberant abdomen, and that was felt initially to be obesity. And although she was a little obese, this was mostly due to very profound constipation. 2 Greek patients were then described, a father and daughter. And you can see the daughter is again short, as is her father, with increased head circumference in both. And then the 48-year-old lady on the right was the first adult female to be described. And she had been in an institution for most of her life, had a very severe learning difficulty, and could only speak in single words. So she was very profoundly affected. Here are some of the other patients who have been described. And I think it's very helpful actually for you to be able to see the facial features of patients with this condition, because it can be very difficult to diagnose. And so it can be helpful to just bear in mind the facial features that one might see. So they often have a flattened nasal bridge with an elongated philtrum, puffy or prominent lips. They often have quite puffy skin with skin tags. The majority of patients with RTH alpha have a neurological phenotype. So I've mentioned already that their head circumference is increased, but their actual brain volume is reduced. And this is termed microencephaly, which you can see here on the MRI image. Many of them, if not the vast majority, will have a history of delayed developmental milestones. They have a reduced IQ, slow dysarthric speech, which is often quite obvious. They can have slow initiation of movement and an ataxic gait, dysdiadochokinesis, fine and gross motor incoordination, and seizures. Here are some of the skeletal features in childhood on the left and in adulthood on the right. So children have a delay in the closure of their fontanelles. They often have epiphyseal dysgenesis. They have delayed tooth eruption and quite severe delay in their bone age. Adults have closed sutures by this stage, but they have thickened skull vaults and thickened cortices of the long bones. This picture on the left is from the first patient who was described, the 6-year-old that I first mentioned. And you can see why her abdomen was so prominent. She has really dilated bowel loops. And this was due to exceptionally severe constipation, to the point where surgery was being considered prior to her diagnosis, because this was such a severe problem for her. And the thing about RTH alpha is that their biochemistry can be abnormal, but it can often just be very mild. And indeed, patients have been described who have completely normal thyroid hormone biochemistry. So it can be very difficult to diagnose. And this is probably the main reason why we have only recognized it recently. Their TSH is normal. Their T4, if abnormal, will be low or low normal. T3 is high or high normal. And reverse T3, if you have the ability to measure it, is often but not always low. Creatine kinase is high, probably reflecting skeletal muscle hypothyroidism, and they often have an anemia. So this is a summary of the features of resistance to thyroid hormone alpha. So they have normal signaling through the HPT axis, which certainly probably explains why their biochemistry is normal or almost normal. They have a low metabolic rate due to skeletal muscle hypothyroidism. They have skeletal dysplasia, increased head circumference, developmental delay, as I've shown you, a very subtle bradycardia, which often not picked up clinically, and anemia, constipation, facial features, which I've mentioned, and they can also have macroglossia. So how do we treat these patients? So as I've mentioned, all of these patients are heterozygous. So we're hoping that if we give thyroxine, we can super stimulate the wild type form of the alpha receptor. And so the first patient that I described has been treated with thyroxine from a young age. And you can see that she was falling off the centiles in terms of her height, but she's now crossed them. And she's actually most recently now up at the 50th centile for her height in response to thyroxine therapy. And her weight has also improved proportionally for her height. But the difficulty with managing these patients is it's very difficult to titrate the thyroxine therapy because we're used to using TSH, T4, T3 to guide us. But of course, that's only reflecting the action of thyroid hormone on the beta form of the receptor centrally. And so it's not telling us how much thyroid hormone is acting on the alpha expressing tissues. So we do measure the thyroid hormones, and you'll see that it looks frankly thyrotoxic, which is the way we would normally describe it. And we measure their basal metabolic rate, and we're trying to get it up to normal. And so by giving her quite a high dose of thyroxine at 225 micrograms daily, we have normalized her basal metabolic rate. I'm going to go on now to talk about defective thyroid hormone transport and MCT8 defects. So the defects here is in terms of the entry of thyroid hormone into the cell. So there's no defect at the level of the thyroid hormone receptor. The problem is all about getting thyroid hormone into the cell. And so a really important transporter for thyroid hormone in the brain is MCT8. And in fact, it's crucial for thyroid hormone transport into the brain. And so patients with MCT8 defects, or the so-called Allen, Herndon, Dudley syndrome, cannot transport thyroid hormone effectively into the brain. So they have cerebral hypothyroidism, and they have a very profound neurocognitive impairment. They tend to have a raised T3, and MCT8 is not crucial for thyroid hormone entry peripherally. So this raised T3 enters the cells normally, and so they get a tachycardia, hypermetabolism, a raised GF4, a low lean body mass. So they have combined problems. The MCT8 transporter is encoded by a gene that's located on the X chromosome. And so the vast majority of patients who are affected are male. And it's estimated frequency of 1 in 70,000. So it's very rare. And these patients have severe delay in cognitive development. They have central hypotonia, as you can see in the pictures here. They have spasticity and dystonia in the extremities. And they have signs of thyrotoxicosis, like I've just mentioned. If you were to image the brain at a young age, you can see hypomyelination. And as I've mentioned before, thyroid hormone is really important for normal myelin development. These patients mostly have abnormal thyroid hormone biochemistry. So they have a lowish T4 and a raised T3 and a TSH that's usually within the normal range. Their average age of diagnosis is 24 months. So they will be diagnosed most commonly in childhood. Very rarely patients have been diagnosed in adulthood if they have milder phenotype. But their onset of symptoms is always in childhood. And most patients present because of gross developmental delay and hypotonia. And the sad thing about these patients is that they die early. So the median age of death is 10 years. And you can see that here by the survival curve shown in the figure here. And the causes of death are respiratory, sudden, or unknown in a smaller number of patients. And it's been shown that a low weight and a lack of head control is associated with an earlier death. So that might be a good target if we're trying to identify treatment for these patients. So up until recently, there was no known effective treatment for these patients with a devastating condition. And the results of the use of Triac, so the same thyroid hormone analog that I mentioned before, was published in 2019. So the Triac 1 trial was a phase 2 trial that was conducted in 9 countries on 45 patients. And all of these patients were treated with Triac for 12 months. And the reason Triac was chosen was because it's not dependent on MCT8 for thyroid hormone transport into the brain. And so it can enter neurons and it can activate the thyroid hormone receptor. And so it can turn on thyroid hormone target genes within the brain. It also reduces TSH. And hence, it would be expected to reduce the T3 level, and that would improve the hypermetabolic features in these patients. So the primary endpoint here was a change in total T3 levels, and you can see that they all had a reduction in T3. Secondary endpoints included body weight, so patients improved their body weight by 2.7 kilograms, and their resting heart rate also dropped. So it seemed to improve their hypermetabolic defects. There were a few adverse effects, and there was one death which was unrelated to the treatment. But we don't know if Triac, if started at an early age, can improve their neurocognition. And of course, that would be wonderfully helpful for these patients and their families. And so the Triac 2 trial is undergoing recruitment at the moment to try and recruit patients at an earlier age to see if neurocognitively there can be an improvement. The last form of RTH I want to mention is selenoprotein deficiency. And so here the defect is in thyroid hormone metabolism. So this is conversion of T4 to T3 by deiodinase enzymes. So selenoprotein deficiency is really exceptionally rare. And you may recall from early biochemistry days that selenium is an essential micronutrient. And selenium exerts its effects through incorporation of selenocysteine into selenoproteins. And humans have 25 selenoproteins, and they have diverse roles. And we don't know the roles of all of these. Selenoprotein deficiency is caused in humans by mutations in the gene encoding a protein called SBP2. And SBP2 is essential to incorporate selenocysteine into selenoproteins. And so if patients are deficient in this, they're in turn deficient in the selenoproteins. It's very rare. There's only fewer than 20 cases described worldwide. And because one of the selenoproteins are deiodinase enzymes, patients have a defect converting T4 to T3. So this is an adult male with this condition, and you can see his T4 is very raised, T3 is at the lower end of normal, TSH is normal. And because selenoproteins have diverse roles, the phenotype can be variable. So there's the deiodinase effect, as I've mentioned. Patients have a muscular dystrophy because selenoprotein N is important for skeletal muscle health. Males are infertile because of azoospermia. There are a number of selenoproteins that are important for spermatogenesis. And patients often have photosensitivity. They can have increased fat mass and abnormal adipose tissue function and sensorineural hearing loss. And these are due to loss of antioxidant enzymes. And a recent phenotype is aortic degeneration and aneurysm, which has also been reported to perhaps be due to lack of antioxidant enzymes. So this is a rare condition. We won't see it frequently, but it could present to us as endocrinologists or our neurology colleagues or even cardiology colleagues. So it has diverse phenotype. So I want to leave you with this summary of the conditions I've described. So I've listed here the frequency, the thyroid hormone biochemistry, and the clinical features that you'll see in each condition. And I'd like to draw your attention to the fact that the biochemical phenotype in RTH alpha and MCT8 defects are very similar, but they can usually be readily distinguished because their clinical phenotype is quite different. Here are some useful resources if you encounter a patient in whom you suspect RTH of any form. We are publishing a review article on clinical endocrinology this year, which will be freely available. There will also be an approach to the patient paper in JCM, and there's a review of RTH alpha published a few years ago, which is freely available online. I want to thank you so much for your attention and for asking me to take part in your wonderful Congress. And I'd also like to say, if you suspect any of these conditions, you're not sure where to go or how to investigate them or even how to manage them after you've diagnosed them, I'm very happy to give advice by email. My email is there, and I'm always happy to give advice on these interesting patients. So with that, I thank you for your attention, and I hope you have a wonderful Congress.
That was an excellent overview for thyroid hormone resistance.